All right, so we're going to talk about SIADH and DI. It's kind of with your, it's a brief section. It's part of technically threats to neurosensory because when you have an injury to the brain, you can have injury to the posterior pituitary gland, which is what this is. So SIADH and DI are both disorders of the posterior pituitary gland. So what does the posterior pituitary gland, that's like a tongue twister, what do you think it excretes? ADH, yep, antidiuretic hormone. It also excretes oxytocin, but we're going to be focusing on ADH. So what does ADH do? Yep, regulates fluids. So ADH, we also know it as vasopressor or AVP. It regulates water balance and osmolality. So if we have an overproduction of ADH, we have syndrome of inappropriate ADH, SIADH. If we have an underproduction, we have diabetes insipidus. So SIADH, we said it's what? Over or underproduction? Over, right? So high ADH. So if ADH regulates your fluid balance and we have too much, what do you think we're doing with water? We're keeping it, right? We have this increased water reabsorption in the renal tubulars. It basically, ADH helps increase the permeability so that water can be sucked back into the body better. So what happens if we're keeping all this fluid? What happens to the fluid inside your intravascular space? It's going up, right? What about the fluid going out of your body? It's going to be down, decreased. Huh? Mm-hmm. For both, yeah. So it can be older adults, malignancies, typically small cell lung cancers. Or, well, we see it a lot why we're talking about it is because of head trauma and because of tumors or any metabolic disorders. Typically, if it's because of head trauma or drugs, which again is what we're talking about, it's self-limiting. Disorder. So these patients, it's okay. It's okay. All you need to know is that high ADH, you're reabsorbing the water, so your intravascular volume is up. So these patients are fluid retaining, right? HTO is going back into circulation. So their serum osmolality is doing what? Going up or down? Down. What's happening to their sodium? Down. Why? Now, is sodium really going down? No. It's just getting diluted, right? So if you have if this is, let's say this is your little vein, and you have a sodium to an HTO and a sodium to an HTO, then that's equal, correct? Now all of a sudden, you have more water all over the place. Has anything changed to your sodium? No. But is it decreased technically? Yes. So that's where the serum God, I can't talk. That's why we need to have a break. goes down. Because you're not really losing anything, you're just diluting it all. What happens when you have low sodium? What kind of symptoms do you get? Confusion. What happens to your muscles? Muscle cramping, right? Twitching. So if you have a patient that has a head injury and you're worried about SIADH and they're maybe having symptoms of it and they start getting a little muscle cramp, would you be worried that maybe you need to get a CB or a CMP or a BMP to see what their sodium's at? That's how we use in level 4 where we apply knowledge. They're not going to ask you that patient with SIADH, do they have high or low sodium? They're going to ask you something like, you have this patient who has been diagnosed with SIADH and they have muscle cramping. What are you going to do? Does that make sense? You have to start tying these pieces together like that.
What did you said? CMP and
CMP, complete metabolic panel, and BMP, basic metabolic panel. So their urine is going to be super concentrated, right? Water's being reabsorbed, so it's not going out. So the urine output's going to be low. So just like we had that kind of dilutional where we had all this water invading, now we have, again, it's the same theory as up here, but instead you had sodium and water, and now you're taking away the waters. That make sense? If you're retaining a bunch of fluid, what's your body weight going to do? Anyone who's had Chinese food and then the next day knows that you are often bloated. Huh?
we don't eat that stuff.
Vomiting. They can get abdominal cramps. And then if it's maintained, all the scary stuff, seizures, cerebral edema, lethargy, headache, confusion. But this is kind of what we're focusing on. That there's serum hypoosmolality, they get this dilutional hyponatremia, concentrated urine, low urine output. Because that's how we're going to diagnose them. We're going to look at their urine. We're going to look at their serum. Serum's going to be down. What's their urine-specific gravity or their urine sodium going to be? Up, right? Yes.
Do you also get like crackers and from like?
You could, from fluid overload. Yep. That's actually, we're going to talk about that because when you're doing your assessments, you're going to monitor heart and lung sounds.
So that's what you would find, decreased serum and
Decreased serum osmolality and increased urine specific gravity.
So you're basically getting rid of it, the gravity is going to show how much of the sodium is out.
Uh-huh. The sodium's going to be up because it's super concentrated because you're not peeing.
You're not peeing out water.
Yeah. So how do we treat these patients? Obviously, we need to treat any underlying cause. If it's a malignancy, we treat the malignancy. If it's a head injury, we're going to treat the head injury. There are meds that stimulate the release of ADH. So if they're on a medication, I believe it's page 1193. If they're on a medication that's affecting and secreting ADH, we want to stop that medicine.
1193.
I think it's 1193. Someone with a book would have to double. Is it correct, Bree? If they have mild SIADH, what do we have to do to fluids? Decrease it, right? Restrict it. But they're not restricted as bad. 800 to 1,000 mLs per day, which to me would be horrible because I drink about like 72 waters a day.
1193.
Yeah, it is 1193. Okay. So if it's mild, typically we can treat this while the underlying cause is being fixed. We just fluid restrict them because we don't want them to just keep reabsorbing all this water. Because even though their urine output, you would think, a lot of times you're like, oh, urine output's low, I need to give them more fluids. Giving them more and more fluids is not going to change their urine output. All that's happening is that that fluid that you keep piling onto them is just getting reabsorbed, and you're going to cause that dilutional natremia to get worse. So we don't want it to get worse. We're not, normally, yes, we would treat low urine output with fluids, but in this case, we want to restrict fluids. If it's more severe, like they have severe hyponatremia, we might need hypertonic. Especially if the sodium's less than 120, they may need a hypertonic solution or fluids. We can give Lasix to help get rid of some fluids, but you have to make sure that your sodium is above 125. Because remember, these are loop diuretics, and you have to be careful with your potassium and sodium balance anyways. And these patients are severely restricted. They get less than 500 mLs a day. Again, we don't want to fluid overload these patients. If it's chronic, meaning that this is something they're going to have long term, a lot of education is needed regarding fluid restriction. These patients are not unlike a mild form caused by a head injury. They, for a short period of time, restrict their fluids. These patients long term.
Can you let them drink alcohol?
I'm not supposed to recommend that, really, ever.
I mean, but it stops the production of ADH, right? Stops
I
the
mean,
secretion.
I guess it's right, but I wouldn't worry about that for.
It's a fun dog.
Please increase your.
You could supplement your diet with sodium and potassium. And teach them signs and symptoms of any fluid or electrolyte imbalances. So teach them that if they might get some muscle cramping, if they're feeling muscle cramping, that their sodium's dropping, or if the family member notices a seizure, that they call and say, this patient has chronic SIADH, they're having a seizure, I'm worried about their sodium. It helps direct care, and patients need to know that. It gets them their care faster and gets them their treatment faster so that we prevent long-term complications.
What is that?
Nausea, vomiting, cramping,
Seizures.
i.e. decreased sodium
Oh,
equals seizures, nausea, vomiting, cramping, like an example of what you're going to teach them. And like we said over here, I'm sorry, what is your name? Jessica. You're going to monitor I&O, obviously, very closely. Their vital signs, but also heart and lung sounds, because if they're retaining all this fluid, they can get muffled heart sounds, they can get fluids on the lung, you can hear crackles. Daily weights are really important. So this is on the other spectrum, we have diabetes insipidus. So if SIADH is an overproduction, diabetes insipidus is what? Underproduction, right? So low ADH. Now, this can either be because ADH is too low, or the renal response to ADH is low. The kidneys aren't responding. There may be ADH in there, but the kidneys aren't responding to it. Yep. And that's what Miss Lewis will talk to you guys in test 4. She'll talk to you about renal disease. So, decreased water absorption in the renal tubulars. So either there's not enough ADH. So ADH, remember, ADH helps make the renal tubulars more permeable. That fluid can flow in and out easier. So if you have too little ADH, the fluid is not being able to be reabsorbed. If you have too much, it's like a hole. You have too much ADH, that hole opens really big to allow fluid to pass out. If you have DI, that hole becomes really small, fluid can't get out. Does that make sense? So, and it can be either because there's not enough or because the kidneys aren't responding. So what's going to happen to your intravascular space? It's going to decrease. And again, there's different types. Don't freak out too much about the types. It can be central, where there's a brain injury tumor, and this interferes with the actual making of ADH. So interferes with ADH synthesis.
Diabetes insipidus, is it just this or in addition to hyperglycemia?
Just this. Just
No
this.
sugar problem.
Yeah. Yeah, no sugar. I know it can be confusing, but no, it's just this. It's way more dramatic than the other types of diabetes insipidus. You can be nephrogenic, which again, this is what we're going to talk about later, where either you have, there's a drug like lithium that causes renal damage, or you have renal disease. And so even though you have a normal amount of ADH in your body, because your kidneys are damaged, they aren't responding correctly to the ADH. And then primary is an excessive water intake. Again, I would focus on, it's the two main types that basically it's just either you're not producing ADH or your kidneys aren't responding to it.
Is that drug, renal damage, renal disease?
Yes. A drug causes renal damage or you have renal disease.
Like your sick patients that are on lithium. Because they're trying to escape lithium values.
You said you were just focused on what, did you say?
I wouldn't spend a whole lot of time on the types. Just know that with diabetes insipidus, that it's either because there's a deficiency in your ADH or your kidneys aren't responding to normal amounts of ADH.
What's that last one? Primary.
Primary, excessive O2 intake. So, what are clinical manifestations? What's what's going to happen to their serum osmolality? Increase. So they get hypernatremia in serum, not in urine. So I would make yourself maybe little diagrams with them next to each other. They have excessive urine output. They pee up a storm, sometimes up to 20 liters a day. Can you imagine peeing that much? They are very thirsty. Polydipsia. They can get really dehydrated. If their oral fluid intake can't keep up with their urinary loss, they get very dehydrated very fast. And if they get very dehydrated and become hypovolemic, it can lead to shock. So it's kind of the opposite. We always talk about urine output. Look at urine output. If they're not peeing, give them fluid. If they're peeing, hold it back. This is totally opposite. So with SIADH, they're not peeing, but we don't want to give them any more fluid because every fluid we give them is just staying on them. But these, even though they're peeing out a ton, we want to give as much fluid as we can to them, or they're going to get really dehydrated. They can get tachycardic, low blood pressure. And just like with SIADH, we make the diagnosis based on the serum osmolality and the urine-specific gravity. So with diabetes insipidus, their serum is elevated and their urine-specific gravity is low. That sodium in their urine is low.
You said sodium in their urine is
Yeah, their urine-specific gravity is low.
Mostly the urinalysis and stuff that you're touching.
Yep.
Any kind of discussion.
Your UA and your serum osmolality. Those are the two you're looking at. So with these patients, Obviously, we want to maintain any fluid and electrolyte balances. They're peeing out a ton. We got to replace those fluids. We're going to monitor their vital signs, their urine output, their mucous membranes, that's the MM, and their neurostatus. They, again, if we can't keep up, if their oral can't keep up with their mouth they're putting out, they get dehydrated, they get hypovolemic, and it leads to shock.
Vital signs.
Urine output, mucous membranes. Sometimes they may need meds to decrease their thirst because they are thirsty. And we talked about the two main types. Central, meaning that there's a low ADH. They might, if it's the ADH is low, we can give meds because remember, ADH is vasopressin, right? That's DDAVP. So we can give DDAVP, which is this analog of ADH, to treat them. That's central. Central means they're missing ADH. And there are meds, that 1193, we can give that mimic ADH and treat it. If it's nephrogenic, meaning that you're producing enough ADH, but your kidneys aren't responding to it, then you might need diuretics or dietary measures. Sometimes indomethacin, which is an NSAID, helps increase the response, your kidney's response to ADH. All right, so just the nitty gritty of that. SIADH is an overproduction. They're retaining fluid. Serum is low, urine is high. DI, they either have too little ADHD or they're not responding to it. They're just massive urine output. So their urine output is low, their serum is high.
If they're massively urinating, why are we giving them thiazide?
Because you're trying, it's a thiazide diuretic that's going to help because it's, remember, it's nephrogenic. So you have enough ADHD, your kidneys aren't just recognizing it or responding to it. So this helps kind of make the kidneys recognize it.
Oh, wait, it's less than 3 grams a day?
Less than 3 grams a day.
Oh, I thought it was 36.
3 grams.
Gotcha.
Would we give 36 of sodium anyways?
Well, I didn't know what 36 was, like 36.
Yeah, less than 3 grams of sodium per day. Low sodium diet. Sorry. 36 would be a ton. That's like a salt lick.
I get that the
All right, so any questions regarding this? No. You guys need about 15 minutes?
Yeah.
All right, go take 15 minutes.